Hey everyone, welcome. Today we're going to talk about something huge. One of the most common and frankly trickiest things we deal with in nephrology, high blood pressure in our dialysis patients. If you're a trainee, this is your bread and butter. You're going to see this every single day. So let's get right into it.
All right. I want to start with a number that should really make you sit up and listen: 86%. In some studies, that's how many hemodialysis patients have hypertension. This isn't some side note, folks. It's the main event in a lot of dialysis care, and it's something we absolutely have to get right.
So here's how we're going to break it all down. We're going to start with just how big this problem is, then dig into the real root cause. Spoiler alert, it's volume. After that, we'll cover how to measure blood pressure the right way, walk through a super simple two-step treatment plan, and then figure out what to do when that plan doesn't work, and touch on a really weird paradox you'll see in the unit.
Okay, first up, let's talk about the sheer scale of the problem. You really have to appreciate how widespread this is before you can manage it well.
I mean, the numbers here are just staggering. Like we said, it can be as high as 86% in our hemo patients. For peritoneal dialysis, it's a bit lower, maybe around 30%. But here's the kicker. That last point is huge. Over 80% of patients are already hypertensive the day they start dialysis, and it's almost always because they are just full of fluid. Okay, so this is where things get a little weird. If you only look at the blood pressure readings from the dialysis unit, you see this funky U-shaped curve for mortality. It says that really high blood pressures are bad, but also that really low ones are bad too. Now, that doesn't quite make sense, does it? And that's our first big clue that these in-center readings are flawed. A lot of times that low BP just means the patient is sicker and more frail, not that their pressure is well controlled.
Right, so if those in-center readings are kind of junk, what are we supposed to focus on? Well, that brings us right to the root cause. It's not enough to know it happens. We have to understand why it happens to treat it.
Here it is, the main takeaway, the number one thing to remember. It's all about volume. That's the main bad guy here. When our patients can't make urine, that fluid builds up, it cranks up their cardiac output, and over time, it stiffens up their blood vessels. That is the core problem we need to attack. Now look, it's not just volume, right? There are other things going on. The sympathetic nervous system gets revved up, the RAS system is active, and even stuff we do, like giving ESAs, can play a part. But while all that is happening, the one you can actually do something about, the biggest lever you can pull, it's almost always going to be volume. And that brings us to something that's just so important in our day-to-day practice, how we actually measure the thing. Because if your data's bad, your treatment decisions are going to be bad too. And those in-center readings, they can really lead you astray. So let's just cut to the chase and ask the million-dollar question. Can you trust that blood pressure number you see on the dialysis machine right before a treatment to make your long-term decisions? And the answer, from all the evidence we have, is a resounding nope. Not at all. Let's put them side by side. Those in-center BPs, they're all over the place and barely correlate with what's really going on. In fact, they often inversely predict how a patient will do. That's that weird U-shaped curve again. On the other hand, home blood pressures recorded by the patient, that's the gold standard. They're accurate, they tell you what's really happening, and they directly predict outcomes. It's not even a close contest. Okay, so what do you actually do? The protocol is super simple, and this is what you need to tell your patients. Have them check their blood pressure at home twice a day for the 4 days right after their midweek dialysis session. That little window gives you the clearest, most reliable picture of their true blood pressure, far away from all the chaos of the dialysis treatment itself. All right, so now we've got good data. We know how to measure. Now we can finally talk about treatment. And our philosophy here is simple. You got to remember this. Volume first, meds second. The whole game of volume control comes down to one single concept: dry weight. And let's be really clear what this means. It's not some number an equation spits out. It's a clinical target. It's the lowest weight a patient can handle without getting symptoms of being too dry or too wet. Getting them there is goal number one. So how do we actually get our patients to their dry weight? You do it slowly. You probe their target weight down, maybe half a kilo at a time. And this is absolutely critical. You have to hammer home salt restriction. Why? Because salt is what makes people thirsty. Telling them not to drink without telling them not to eat salt is a recipe for failure. And if you're still not winning, you may need to give them more dialysis, either longer or more often.
Look, only when you're sure you've done everything you can on the volume front should you start adding more meds. And the evidence gives us a pretty clear playbook. Step 1 is a beta blocker, something like atomtolol. If that's not cutting it,
Step 2 is to add a calcium channel blocker like amlodipine. ACE inhibitors and ARBs, they're usually third in line for this crowd.
All right, so what numbers are we actually shooting for? Remember, we're using those home blood pressure readings. For our hemodialysis patients, the goal is to be under 140/80. For our peritoneal dialysis folks, whose fluid status is more stable, we can be a little more aggressive and aim for under 130/80.
Okay, but we've all had that patient, right? You've squeezed their volume, they're on 3 different meds, and their pressure is still sky high. What do you do then? This is when we have to put on our detective hats and investigate for resistant hypertension.
Hold on. Before you just slap on a fourth medication, you got to think, what else could be going on? Are they actually taking their pills? Are they popping NSAIDs for pain? Is their ESA dose too high? Is their dialysis prescription just not enough? Could there be something else going on, like renal artery stenosis? You have to investigate, not just prescribe.
So, you've done your homework, you've ruled out all those other things, and it really is resistant hypertension. Then the next move is often to add a really potent vasodilator, something like minoxidil on top of everything else.
All right, for our last section, let's get into a really weird and confusing thing you'll definitely see in the unit: the patient whose blood pressure actually goes up during dialysis. I mean, stop and think about that for a second. It makes no sense, right? We're pulling off fluid, which should make the pressure go down, but instead it goes up. It's a total paradox. The mechanism isn't totally clear, but we think in some patients, especially those who are still volume overloaded, pulling fluid triggers this massive surge in sympathetic tone or hormones like endothelin. So what can we do about it? First, and I can't stress this enough, you go back and challenge their dry weight. More often than not, this is a sign they're still secretly overloaded. You can also try switching their beta blocker to something like carvedilol, which might help block that endothelin release. And another trick is to lower the sodium in the dialysis fluid. So let's wrap up with this thought. The next time you're rounding in the dialysis unit and you glance at that blood pressure on the screen, ask yourself, is that cuff really giving me the full picture? Or is it time we changed our whole approach, empowered our patients to check their own pressures at home, and finally started treating the real hypertension?